Well, hello everyone, and welcome to today's webinar on maximizing the value of trauma video review. My name is Carlene Anto, and I lead the marketing team at Surgical Safety Technologies. And I'm very excited to hear from Dr. Ryan Dumas today about how trauma video review is being used to really see the big picture in trauma care and help inform process improvement. As a former trauma nurse, I vividly remember caring for many trauma patients in the ED, but I was always at the same time very surprised in the debrief just how myopic my memory was. And I wasn't alone. I think that's what makes trauma improvement such a challenge. So I'm excited to hear what Ryan has to say. But before I turn the session over to him, just a quick note that microphones are muted for noise management, but you can enter questions in the Q&A feature at any time. And always get this question. Yes, we will send a link to the recording after this webinar. So our featured speaker today is Dr. Ryan Dumas, who has been using trauma video review really for a number of years and is also now serving as a strategic advisor to Surgical Safety Technologies in trauma care. So Ryan, would you mind kicking off the session with just a little bit of background about yourself?
Yeah, awesome. Thanks, Carlene, and thanks for the invitation and putting this webinar together. So I'm an associate professor of surgery, and much like Carlene, I'm a trauma surgeon really by training and by passion. And I was shocked and really surprised when I was a fellow, really getting into trauma, that we didn't have a better way to analyze and really examine the way we take care of our trauma patients, especially after the moment has passed and the dust has settled. And I got exposed to video review over 10 years ago as a fellow, and since that time have really made it my passion project as far as implementing it, using it for education, but also really using it for research and maximizing how not only we acquire these videos in the best and possible way, but also how we use them. And really it was the ultimate goal of improving the care we provide to our patients, because anybody who's been involved in trauma resuscitation knows that it's chaotic, sometimes it's what I like to call controlled chaos. So, I have about 20-ish so slides. I want to get through them relatively quickly, but really to maximize time for engagement and opportunities to ask questions. And we want the session to be as interactive as possible. So we're going to kind of jump right into it. So we're going to talk about really kind of rethinking performance evaluation in trauma care. Trauma video review is well beyond just watching videos. It captures everything. I mean, it's a camera lens, so people in and out of the room, noise, non-technical skills, technical skills, how those all interplay during trauma resuscitations and during acute traumatic resuscitation. Because I'll tell you, trying to figure out what happened from the electronic medical record is fairy tales. Because simply, you couldn't, even the best of trauma nurses can't possibly capture everything that happens. And there's certainly no data on things like non-technical skills and leadership. And for example, how many people were in the room and what was the tone and the chaos like. So we're going to kind of talk about that. It's much more just observation. And then really, I want to talk to you a little bit about how I've used it in my work to measure team performance too, because now we have this great tool to measure performance. And, we know the American College of Surgeons that verify our trauma centers want us to do certain things within certain time metrics. And so we have to be able to do that. And we have a much better tool now to do that with video. We'll take a look at some of the research that we've done and some of my group has done, looking at some of these things and trying to define once and for all what really happens in the trauma bay, because it very much is a black box when you try to recreate a trauma. And then of course we'll leave some time for questions. So currently trauma performance improvement relies on the electronic medical record. It's fraught with problems, as anybody here who's been in medicine knows. Team recollection can be vague, can be incomplete, so as well. And so trying to rely on team members to recreate a trauma doesn't always work either. And our trauma registries and our trauma registrars are as good as they are, don't capture any of the non-technical skills or intangibles of trauma resuscitation. And certainly simulation has played an increasing role. and team performance plays an increasing role for how we train and educate our teams. But I'll tell you, there's nothing also like sitting back and watching a video to review a team's performance. And so, this is what a video review conference looks like. This is a bunch of surgical trainees and fellows and physicians sitting around and watching tape, where we have a controlled environment and we can debrief and we can watch tape and get better and dissect what we did. We can pause, we can rewind, and we can go through everything. Because, we've shown this, and this has been shown in several capacities, both in pediatric and adult literature, that basically, when you look at something like thoracotomy, these are time stamps, benchmarking. So we benchmark thoracotomies, the procedure, and we just compared essentially what was available in videographic data compared to the electronic medical record data. And, sure enough, not surprisingly, almost all the data is absent in the electronic medical record, and almost none is absent in video review. Because you can pause, rewind, you can zoom in, you can fast forward. And we've actually taken this a step further, and we compared video review to in-person data collection, and still video review wildly outperforms in-person trained scientists that are studying these trauma resuscitations as well. And certainly in pediatric populations too, you can see here on the study on the right that severely injured pediatric trauma patients, 54 errors were in 22 patients were identified, but only 10 of these were identified when using the electronic medical record. So I think it's an easy case to make, and I probably don't have to convince any of you guys that the electronic medical record for trauma is just impossible, because trauma is taught in a vertical fashion, ATLS, it's A, B, C, but really in practice it happens horizontally, where things are happening together and the team is functioning together. And this is the study that I mentioned, specifically looking at, so we train people to sit and watch thoracotomies in the trauma bay. So these are that's all they do. That's their job, is to watch. And still, it's woefully incomplete, where you have more than 60%, for example, of repaired cardiotomy not documented and with in-person prospective data collection. So it's absolutely critical to have a better way to do this, and videographic data is really the answer. Because our current approach is incomplete, it's inaccurate, and really it just relies on one, maybe two or three individuals. It's the nurse documenting, and it's the physicians that were involved. And it's well documented that physicians' perception of time changes during acute trauma resuscitations, and so trying to put this all together with an electronic medical record just doesn't work. I think for me, I've been particularly interested in the team aspects, right? As leadership, for example, was there a leader that was present throughout? Were they standing in the correct position? Were they orchestrating the resuscitation in a manner which was moving things forward? We just published on time management as well, and we can talk a little bit about that more. But also, we've recently published on just movement. We measured with video patients going in and out of the room. And sure enough, there's a direct correlation with how a team performs on non-technical skills and movement in and out of the trauma room. So all that now is being able to see and identify on a video. So it's absolutely critical, because really, if you think about it, this is not unique to surgery. I mean, we're high-performing teams. Really, video review and performance improvement using videographic data was started by athletes, right? Even athletes in high school look at video and they watch tape, right? And so why should we not be doing exactly the same thing, identifying the key players in our team and how they're all functioning and how we can optimize their care? So, video review actually really has been around since the early 90s, late 80s. Hoyt and Shackford first published about video review in the late 1980s. They just did a simple project. They looked at trainees that participated in a video review conference, and they compared their outcomes, their team outcomes, compared to a group of trainees that didn't. And sure enough, people that participated in the conferences had more compliance to ATLS guidelines and assigned roles, and the teams functioned better. So this is old data that we publish now. It's almost almost 10 years old, because the data was acquired in 2016 through 2018. But we essentially did a survey of EAST, which is our largest trauma organization. And at the time, there was 30% of centers using trauma video review. And I can guarantee you that number has dramatically increased. Almost every week now, or certainly every other week, I'm emailed by a center asking like, hey, we're kind of interested in starting this, or we are starting this, how can you help? And so it's kind of fun to see this kind of take off a little bit. And I think, these numbers are dramatically changing, and be interesting to repeat the study here in another few years, because this 20% of centers that were planning to start a video review program in 2018, I can tell you that number is very real. And what's made this easier too is the technology. I mean, there's no doubt that the technology has been increasingly available and secure for this kind of application. So consent always comes up. The vast majority, and this is data that was presented in the survey that I just showed, the vast majority of centers consent patients with a consent for treatment, and medical photography or videography is part of the consent for treatment. So, I think patients really more increasingly almost expect this kind of care, in the sense that they expect their teams to be using videographic data for quality and performance improvement. And so much so that centers that previously had required consent for video review, there are some centers that do require explicit consent, have no longer require consent, because I think as it becomes part of the culture, everybody becomes more comfortable with videographic data. So, other considerations too, for those of you guys that are practicing obviously throughout the country, there are certain states, for example, that have one versus two party consents. And so it is important for you to understand how your state laws may impact video review. So in a two-party consent state, with which the vast majority of states are not two-party consent states, both parties have to agree to be videotaped or video recorded for data. And so that's important to keep that in mind. But I think, and we've published on this, we did a literature review of this. I think my interpretation of the literature, and certainly the case law, is that the benefits in culture and the team performance benefits and the improvements that we can garner from video far mitigate the very, very small potential medical legal risk that there may be. And really importantly, it's really well perceived. So, in survey studies that we've done, almost universally it's well perceived. Usually centers that stop doing video review are centers that essentially don't have the bandwidth, because it does require some people and some infrastructure to help review videos and establish a PI, an education conference. But it's always been well received by nursing and other people who are involved in the training process, in the video review process.
Hey, Ryan, before you move on, we had a question that came in that might be appropriate to address right now, which is, what about clinician consent? How do you address physician hesitancy to be recorded?
Yeah, that's a great question. Absolutely a great question. It comes up not infrequently. I will tell you that I've practiced at 3 centers now that do video review, and I've spoken to countless across the country. While it always comes up in theory, I would think in practice, I have never heard of a physician just outright refusing to participate, in the sense that, what the key is that is never to be used punitively. It's not video review is not a punitive tool. It's a tool to look at team performance. It's never about an individual. If you think it's about you, then you've totally missed the point. It's kind of what I think. And so it's not at all about that. It's about improving teams, improving dynamics, improving communication. And quite honestly, it's all about highlighting stuff that's done really well sometimes, because we can't find those instances in the EMR. You can't see a good debrief. You can't see a good pre-arrival timeout. And so that's really what the power is. And so I'll give you an example at UT Southwestern, which does a lot of video review. They initially had a consent for the patients to sign off, and everybody was saying yes. So basically, they took it out. Now, I realize that's not what the question was. The question was specifically about providers. But we have not, basically what we have done in the centers I've worked at is just we've changed the culture. We've been like, this is part of our culture. This is how we're going to address and improve performance improvement. And this is the best possible tool to do it. And so this is what we do here. And I haven't had anybody say, oh, I quit and I leave. Certainly nurses, not at all. In fact, a lot of times the nurses will come up to me and say, hey, wow, we had a great case last night, or this went really well, we should watch that. Or, hey, we could have maybe improved the communication with our ED colleagues. Can we take a look at the video? So I think the more you establish that culture of performance improvement, it really becomes much less of an issue. And the key, back to bring it full circle, is just not using it in a punitive manner. So, I think, and to address some of these things too, the technology has evolved dramatically, right? So when Hoyt and Shackford published it, this is the paper, this is the picture from their paper, this is what they were using. And I don't need to tell anybody here that you can't walk anywhere in your hospital without being on camera. From the moment you park your car, you're on a camera. From the lobby, in the OR lounge waiting for your case, there's a video feed. Almost surely there is. And so, and now with SST and the trauma black box, to further alleviate concerns, it's fully de-identified. So the voices are changed and pitched, and the faces are blurred with very high fidelity. You can see in the bottom right there where it's impossible to tell who's who. So, and importantly, this data now is all stored securely on cloud-based servers, none of which existed even 10 years ago, where the technology is constantly evolving. And so this is what this might look like. These are a bunch of different platforms. You see some here that are not de-identified. You see some with multiple cameras. The one on the bottom left is one single camera. The one on the bottom right is 2 cameras. And then the SST black box platform here on the upper left has 4 cameras in this particular setup and is de-identified. So, the video review can be done in a multitude of ways, all of which now have made it so much more easy to access, to store securely, and then to auto-delete so that videos aren't staying around in perpetuity. And this is specifically our platform, the SST black box platform. It really creates an absolutely beautiful videographic library. And so, this is what the platform looks like. And you have the ability to filter and search for cases based on hemodynamic parameters, for example, or demographic information of the patients. And each resuscitation is clipped out for ease of use and visibility, and allows you to easily, quickly identify patients and trauma resuscitations of interest. And then, videographically, the data is displayed in such a way that it's incredibly easy to navigate and to toggle between cameras. And this particular setup even has the vitals monitor, which is incorporated, which is absolutely critical because that allows you to see how physiology is evolving over the course of the care of the trauma patient. This here is also, again, our particular setup here, and hopefully this is playing and coming through. But you can see the team here, and then you'll see kind of the ability to swipe between camera sources to change the angle. And so in this particular setup, you get a really full 360-degree evaluation of the resuscitation, and allows you to unparalleled view into taking the care of this patient. There we go. Additionally, too, more and more of these platforms are becoming integrated into the electronic medical record. And so SST is the only videographic platform that is fully integrated to the electronic medical record, and it allows you to recreate trauma timelines. So with data that's from the Epic. So no longer are we trying to piece together these platforms. The video is synced with the platform, with the timeline, and you even have initial presenting vitals that help you and augment your video review. Because ultimately, this is what we're trying to get to, right? Like currently, we really are woefully deficient in understanding team performance, and team performance is a function of two different things, really. It can be boiled down to 2 different things. It's technical skills, right? For the technical procedures we do, airway intubation, surgical airways if we need to, thoracotomies, chest tubes, vascular access is probably the biggest one, and then it's that with non-technical skills. Right? And so non-technical skills is all the other intangible things that we kind of talked about: situational awareness, leadership, cooperation, problem solving, things that we wouldn't ordinarily capture in an electronic medical record. And together, and only when you have those 2 pieces, can you elucidate trauma team performers during critical events. And so that's what we're trying to get to. And so video review is the solution to that equation. Because now we can establish metrics to completion of critical events. So how long did it take to put that IV in? How long did it take to get that airway in? Right? And then we can combine that with like, oh, it took less time because there was a good leader who was always in the right position and they were moving the resuscitation along. And then we can sit back and relax and identify opportunities, be like, wow, we were very good at vascular access, or we're very slow at it. in these certain patient populations. This is how we could potentially change. And so that allows you to really become deliberate about your performance improvement and much, much more granular because of the data that we can now collate from these videos. And then you can set standards. So it's easy to be like, hey, like I want our ATLS assessments to be done in less than 5 minutes. I want time to intubation from the time the decision is made, verbalized on a video, right, which you would never be able to tell from an electronic medical record, to the time the airway is secure. And so you can benchmark your team now, right? And then you can track and trend. And then all of a sudden, you have robust performance improvement, right? Something that I think is none of this right here can be elucidated from a medical record. So I think even total time of the trauma bay, we've tried to study that before. It's very difficult unless the nurse is really, really accurately documenting. But with the video, you can see it's wheels in to wheels out and to the second, right? So we can measure all these things. So let's look at some of the technical skills. These are both papers that were published by my group, and we looked at two different things in these particular cases. One of them we talked about briefly already, that was thoracotomy, and the other one is thoracostomy or chest tubes. And so you can see here, right, we dichotomized patients into either hemodynamically stable or hemodynamically unstable. And you can see, in hemodynamically abnormal patients, it takes more than 10 minutes from time of entry to time of pleural decompression or chest tube completion. And so, that's a huge opportunity there, right? So now we can benchmark, so you can measure how your team is doing, and then you can benchmark things, you can develop simulations, or maybe your chest tube tray is in the wrong part of the hospital or not even in the bay. And so you can optimize things and figure out why things are taking so long. So we did the same things. We did the same thing with thoracotomy, and actually in this particular study, we found that we were also really slow at vascular access, which prompted a whole other study to look at how quickly we attain vascular access. So these are ways in which we can use videographic technology to identify individual, and some centers may have very different performance metrics than others based on their needs, right? So blood administration is a common one too. How fast does it take to get blood? Where's your blood fridge stored? How well is the communication between the ER and the trauma center or the trauma team for an airway, for example, too? All these things can be measured. So this is the vascular access study that in particular we looked at. So this is what's cool about this study is that it was a 19-center, multi-center trial with centers using video review. So this data now was published in 2023, but the data was collected in 21 from 2022. And even at that time, almost 4 years ago, there was 19 centers that were willing and able to participate in a video review, a study looking at vascular access. And sure enough, you can get second-to-second data. And in this particular study was looking at IO versus other central lines, but more interestingly is just some of the data we're able to acquire with video, right? And we're able to show that in the case of IO is a lot quicker and a lot more effective at obtaining access. Now, it's certainly not a perfect line, but using our videographic technology, we can show that patients that get IOs at least get blood faster, right? Doesn't mean we shouldn't be doing any other, we should always be prioritizing central access and high flow lines, but it takes a lot of time in patients that have exsanguinated. So again, this is something that we've identified and we found in video, and then we search for a solution. Non-technical skills are super interesting. We've looked at this in a number of different ways, but we had a big problem with EMS timeout and try to recreate an EMS timeout from an electronic medical record. If you're lucky, it'll say EMS timeout, right? And that's all you'll get. But now, we were able to count, like we literally counted the number of times physicians interrupted EMS providers and vice versa during an EMS timeout. And you can only do that with a video, obviously. And so we counted EMS timeouts, interruptions, jumps, right? And what information was presented and how much of the information was presented based off a standardized checklist. And what do you guys think? Obviously we suck at it. It's the bottom line. We stink. There's a ton of room for improvement, right? And so we actually, based off of this study, we did an intervention and looked at training our ambulance services and how to do a standardized checkoff. And then, of course, training the physicians on how to not interrupt, basically, right? And so that all came from, video review analysis. And so that has a direct impact on how we take care of patients, because we then showed that patients and teams that have a good, tight, for example, a EMS timeout where we don't interrupt, the whole team performs better across the entire resuscitation, not just that team performance. Because it's a surrogate for a team that functions well, right? It's not too surprising. So teams that function well in EMS timeout are probably inherently going to function better throughout the entire resuscitation. And this one is, I think, maybe arguably even more impactful. This is a multi-center study that we looked at, again, using video, non-technical skills. And basically, for no-techs, which is a scale that we can use to measure non-technical skills, you want a really small number. That means your team's really tight and performing really well. Basically, for every point increase in team performance or degradation, that means that you have more chaos, basically, right? And so we found that for every point increase in no-tech scale, you had almost 2 minutes delay to the next phase of care. So the next phase of care in trauma, we can really go 3 places: OR, CT scanner, or IR, right? So that's really the only 3 places we're going to go. And that is delayed significantly when your teams don't function well. And this is all through the grace and the ability of being able to accurately capture this data and finally be able to have a tool where we can study team performance. And same thing, this is just maybe probably at this point, hopefully I'm getting my point across, but cardiac arrest, right? So these are patients that came in alive. They all were alive, and then they had a witnessed arrest. And then, sure enough, your ability to achieve ROSC is directly correlates to team performance, right? And same thing. That's this study. I apologize. I got my 2 studies mixed up. So this study, you can see there's a direct correlation with the likelihood of obtaining ROSC and in those patients that had a cardiac arrest based on your team performance. So you want your teams to be over here on the screen left, right? Or you want them to be a 5. And then look at the teams who are 5s compared to teams that are 14s, right? And their likelihood of cardiac arrest. And this one, we specifically looked at some of the domains of the no-tech scale, and basically teams that had better assessment and decision-making scores had improved rates of ROSC. So again, this is 3 papers that we're specifically looking at how teams impact outcomes for our patients. So finally, I always like kind of doing top 10 lists, so we can buzz through these, but these are kind of some highlights that I think, really emphasize the critical nature of using video review for performance improvement. And really, because hopefully I've convinced you that it offers an unparalleled way to study team dynamics, leadership, and quality, during trauma resuscitations. We can't really do any of that, or certainly not to the same degree with the electronic medical record. We now can look at like the time a needle hits the flesh, right? And the time a chest tube is done, the time as a retractor is deployed. We could never look at that before, right? And I'll tell you, the overarching theme that I have, distilled down from this is that basically we're not as good as we think we are. And I think that's critical, right? So we can now study and improve. It's very well perceived by physicians, trainees and nurses. People get increasingly comfortable with it, and they actually ask for it. Be like, oh yeah, like we need to watch this video. I think modern cloud-based technology makes it incredibly safe and secure. And HIPAA does protect the use of videographic technology. Let's be very clear. It does allow us to use videos for quality improvement and education. The medical legal concerns I think are overstated, and they're just simply not supported in case law, including a case law review of all video review cases. I'd certainly convince you, I hope, that it's more accurate than EMR data. It's more accurate than in-person data. And it has important implications beyond our trauma bay, right? So now we're looking at video review in the operating room. I do some work with EMS personnel who wear body-worn cameras. We're doing video review in the pre-hospital setting, right? So these are all places that we should be considering using videographic technology. And really, it can hit performance improvement, it can hit education, and it can hit research, right? So that's how you create a robust program when you're using all 3 together. And this is probably arguably the most important thing is like this technology is evolving. It's not going anywhere. It's only getting better. And so I think, leveraging our partners here, for example, at SST, to help us find the best way to do this is critical. And the platform that we've developed has changed dramatically over the last 5 years since I've been kind of working and consulting with the company. It looks nothing like it did before. And so that's critical because it's going to constantly evolve to the need of the provider. And so interestingly now we're looking at using AI, obviously, as you can't really have one of these conversations without talking about AI to help us analyze that data, and take it to the next level. So that's it. That's all I got. So with that, I think we're happy to take any questions and answer any questions that may have come up.
That sounds great. Yes, we did have a few questions come in. The first one was, how long do you have access to the videos?
Yeah, that always comes up. Good question. It is in that survey paper that I talked about that we published, the vast majority of the center is 30 days. So it's nice, and the whole point of that is to protect the institution from a medical legal perspective. The video is auto deleted in almost all these cases, and auto deletes, and certainly in SST, that's exactly what happens. They auto delete and fall off the server, and you no longer have access to the video. I think it's absolutely critical for data security.
All right, and then how do you pick the videos to use or review?
Yeah, also a good question. There's obviously a ton of data here, which is great, but it's also challenging because it's a lot of data to go through, right? So I like to pick videos based on a few things. One, a lot of what we do is what I call high impact, low frequency: thoracotomy, emergency airway, chest tubes, central catheterization. So pick those videos too, right? That's where you're going to get the high injury, high acuity severity, patients. Those are the ones where you can get the most bang for your buck. Also, though, I pick videos where things are done really well, really good EMS timeouts that for example, I just talked about. I show examples of those, and the teams are like, whoa, it's really remarkable to watch a team do a really good EMS timeout. Same with a pre-arrival timeout, for example, right? Or a debrief after a case. You can watch all that. So it's all on video. And so those are good ways and good places to start. I pick things that are done well just as frequently as I pick things that are opportunities where we could have done things better.
And that probably supports the culture, right, of driving.
Yeah, that's the whole idea. The whole idea is to say, hey, we're not using this to browbeat over your heads like, oh, you guys need to do better. That's not all what it's for. It's, hey, look how this team did it. And I've had residents come up to me after, be like, I did an EMS timeout this week because I did it exactly the way the video we watched last week. And I think it's pretty remarkable when you see that in action.
That sounds great. What team members or roles access the videos to assess performance? Like, which stakeholders are involved?
Yeah, good question. I think limiting access is critical in the sense that not everybody needs to have the keys to the candy store, in the sense that, some critical stakeholders are the trauma medical director, the trauma program manager, and at the very least. And then with SST, for example, you have the ability to share videos. So you can share one video with one trainee, for example, or one colleague, and that'll ping them an email automatically. And then you don't have to worry about sharing the entire data set or the entire videographic set. So I think controlling it is important. So I think having at least those two to start, and then if you have interested faculty who, for example, run the video review conference, then they would obviously have access, and you can kind of control access in that way.
Okay, great. Any pearls in terms of how you run educational conferences using TVR?
Yeah, that's always comes up too, which is important. I think my biggest pearl, I always say, if you're the trauma medical director or you're the trauma program manager, and you're trying to start this, put yourself under the camera. So use one of your cases first, right? Establish, make yourself the guinea pig. Everybody will be more comfortable that way, especially if it's maybe not an optimal outcome. Be like, yeah, this is where I totally missed this. I should have communicated better, or I lost sight of the diagnosis, or I got anchor bias, whatever it may be. So put yourself under the camera, I think, is really helpful. Highlight, like I have emphasized a few times now, highlight things that are done well, right? So highlight the things that you guys crushed as a team. And then that gets everybody highlight physiology. I think highlighting terminal bradycardia in a patient, who had a heart rate of 140, and then all of a sudden the heart rate drops to 50 and the team didn't really pick up on it maybe, that's really critical. A team will never miss that again once they see that a few times on video. So things like that, I think, are where you really benefit a lot from the video.
Mm-hmm. Yeah, a couple of other questions. I think you've kind of answered them in some ways about how do you leverage TVR for research and for quality improvement and for education. I know you've kind of given a few examples. Maybe sharing I think I've heard you talk about the blood story once before. That could be another good one to talk about.
I think that's a good example. The blood transfusions always come up. It's like there's so many centers that one of the first things they do is they look at how long it takes to get blood, and it's always longer. Like setting up the darn Belmont sometimes takes a lot of time, right? And so watching that, and just find a problem that you may have, or whether it's like, for example, like intubation, like how long it takes to get the meds, or if they're in the same room, and then just create a data tool where that you just start, okay, this is the time that we asked for blood, right? This is the time the nurse brought it into the room. This is the time it hooked up to the Belmont. This is the time we actually saw it in the IV tubing. All that stuff can now be determined from video. And so, that's what we did with the vascular access study. Basically, we found a problem that we had, and that was that it's very difficult getting vascular access in exsanguinating patients. So we were like, hey, let's just try IO and see. It's not a perfect line, but it can be a bridge to a central line, and things can be happening simultaneously. You can get an IO while you're getting a central line. So find a problem, develop a tool to measure it, and then develop an intervention, right? So your intervention, maybe we need the blood fridge in the trauma bay, right? If it's not already there, or at my shop right now, we have our blood fridge in the trauma room. So, in the proper room itself. And so all to decrease the time to blood administration. So I think finding some key things like that are really helpful. And I think picking leadership stuff is great too. And just how many times are your teams using closed loop communication? Something simple like that. And give good examples, show on the video what a good example of closed loop communication looks like.
Nice. Any other exciting cross-institutional research happening right now with TVR?
Yeah, we're absolutely. There's always, so I run a large group of investigators, which anybody who's doing video review is happy to be a part of. There's over 40 centers that are using video review. Yeah, I think a lot of us are interested in the non-technical skills for sure. We're interested in some airway studies as well. There's always been an interest in those kinds of things. The other big one too that I mentioned at the end is AI. So the Achilles heel of video review, as we've kind of pointed to, which is a good problem, is that how much data you have. So trying to train AI models to study these videos for us and learn off them is what I'm really excited about, and I think this is going to be the future.
All right, I think we've run out of questions. Thank you so much, Dr. Dumas. Really appreciate it. And anyone that has any questions or follow-up can email Dr. Dumas at the
yeah, please. Always happy to chat. Yeah, absolutely. No problem at all.
Thank you so much. Have a great rest of your day.
All right. Thank you. Thanks, everybody.